Hello, and firstly, I'd like to apologise for the delay in getting this to everyone. And I'm sorry that people who logged into CPD Me a couple of weeks ago, I was having lots of technical difficulties, which means I couldn't communicate with anyone and I couldn't get through to anyone to say I couldn't make it. So I've agreed with CPD Me that I will complete this online recorded webinar for yourselves. So firstly, my name's Ben. I'm paramedic, for those who don't know me. I've been paramedic just coming up to 3 years September. I currently work for the ambulance service, but going into a new role soon as a emergency care practitioner. So today we're going to be looking at transient loss of consciousness. Okay, and this is a presentation which a lot of clinicians will come across and deal with. So firstly, what is transient loss of consciousness? So a TLOC can be defined as a spontaneous loss of consciousness with complete recovery. Okay, the key thing there is complete recovery. Other terms for this is faint, blackout, or collapse. The causes of a TLOC can vary. One of the most common cause is a cardiovascular, which is syncope. Second is neurological, such as epilepsy. So the diagnosis of the underlying cause of a transient loss of consciousness is really often quite inaccurate, inefficient, and delayed due to the variety of conditions it could be. So a lot of people are initially diagnosed with and treated for epilepsy due to the fact TLOCs can mimic this as well. So a lot of people who are treated for epilepsy actually have a cardiovascular cause for their TLOC. Some people have expensive and inappropriate tests or inappropriate specialist referral, so that unnecessary referral or referral to the wrong speciality. And then those who are referred to the wrong speciality are actually receiving the inappropriate treatment, which is quite, as you can imagine, quite dangerous. Okay, so that means that potentially dangerous conditions might not receive that appropriate assessment, diagnosis, and treatment. So TLOC can be split into two categories, okay? So we have a non-traumatic transient loss of consciousness, as well as a transient loss of consciousness due to head trauma. We're going to be focusing on the non-traumatic side, okay? So syncope is defined as a transient loss of consciousness due to cerebral hypoperfusion categorized by rapid onset, short duration, and spontaneous complete recovery. A common cause is that orthostatic hypotension, commonly known as postural hypotension. A lot of people might have arrhythmias causing the collapse, such as a heart block or a supraventricular tachycardia. We move on to the epileptic seizures. As we know, are regular and a lot of time are well managed and controlled. The patients and their carers, such family, know what is best when it comes to the seizure. Use these to your advantage. We also have your psychogenic, so your psychogenic pseudosyncope and your psychogenic non-epileptic seizures. Okay, we're going to come on to them in a minute. These two quite causes of non-traumatic TLOCs, which are very hard to diagnose. So syncope. Our first one is that reflex syncope and vasovagal. Okay, so the most common cause of a transient loss of consciousness, sometimes called neurally mediated syncope or vasovagal syncope, is that transient condition resulting from intermittent dysfunction of the autonomic nervous system that regulates that blood pressure and heart rate. Okay, so this could be related to micturition, so going to the toilet, and especially in the elderly, carotid sinus syndrome. We have that orthostatic hypotension, again quite a common one. So this is suggested by an absence of features suggesting an alternative diagnosis and a typical history, including that lightheadedness, dizziness, weakness, tunnel vision, and certain medical conditions and or drug treatment. So it's always beneficial to look at the medications these patients are on. Symptoms will get worse when they are standing, and they are relieved naturally by lying or sitting down. So an orthostatic hypertension is diagnosed by a fall into that systolic blood pressure of at least 20 millimeters of mercury, and then at least 30 millimeters of mercury in people with hypertension, and the key thing there is or a fall in a diastolic blood pressure of at least 10 millimeters of mercury. That is within 3 minutes of standing confirms that diagnosis. Okay, so nice guidelines actually talk about conducting a blood pressure at 1 minute, 3 minutes, and 5 minutes when they have stood up. If the symptoms are that bad, leave them to sit down and relax. You could probably diagnose it from the symptoms they present with. And our last one is that cardiac. Okay, so an underlying cause, cardiac cause, is suggested by an ECG abnormality. That evidence of the heart failure. Okay, blackouts occurring during exertion, palpitations before loss of consciousness. And we've also got to think about a family history of sudden cardiac death in people aged younger than 40. This could be due to an inherited cardiac condition, so we could have also a neural unexplained breathlessness and or a heart failure. Okay, so note that hypotension as well may be exacerbated by that venous pooling during exercise, so that exercise induced after meals and after prolonged bed rest. Okay, we can also have drug-induced hypotension. Moving on now, just your little clinical knowledge summary from NICE regarding blackouts. So epileptic seizures, I'm sure we all know a lot about epilepsy, but epilepsy is suggested by a bitten tongue, that head turns to one side during a blackout, a loss of bowel and bladder control, unusual posturing, so that's tonic-clonic, prolonged limb jerking, confusion following events at post-ictal stage as well. So the history of medical conditions will inform you if they have a diagnosis or awaiting a diagnosis. Okay, so have a look at the GP records if you've got permission. Speak to family and friends. And parents, carers and family will understand a lot about the patient's condition and what is normal for them. So again, use these people to your advantage. So, psychogenic. Psychogenic pseudosyncope is that absence of transient loss of consciousness, is the appearance of transient loss of consciousness in the absence of true loss of consciousness. Psychiatrically, most cases are classified as conversion disorder, which is hypothesized to represent the physical manifestation of internal stressors. So, if a person has persistent transient loss of consciousness, so persistent, it keeps happening, let's consider PPS or PNES. So, the diagnosis of PPS results on positive clues taken from the patient's history and from documenting normal EEG results, normal ECG results, heart rate, beat and BP during an episode or an attack. And we also have your psychogenic non-epileptic seizures. These appear like a seizure but will have psychiatric cause, such as an event or a trigger. A good history taken of the event and patient can help identify this. Note if they have tongue biting, loss of bladder control, etc. So the nature of events changes over time. There are multiple unexplained physical symptoms. They are usually prolonged events. The distinction between epilepsy and non-epileptic seizures is complex, so therefore they will need referral for neurological assessment if either PNES or PPS is suspected. In essence, don't let this idea of pseudo, catch you out. Treat what you find, because like I said, these psychogenic seizure, non-epileptic seizures and psychogenic pseudo-syncope are very hard to diagnose, and a lot of people actually will go through a variety of epilepsy treatment for these. So we also have a lot of rare causes or misdiagnoses of transient loss of consciousness, which we need to be wary of. So falls with amnesia and with no unresponsiveness. You've got your TIA, so that transient ischemic attack. There's always a focal neurological sign and symptom. There's no loss of consciousness with these. And if the consciousness is lost, this is usually lasts longer than a TLOC. Okay. You also got your subarachnoid hemorrhage, so you can use your Ottawa subarachnoid hemorrhage score to help diagnosis, but consciousness may be progressively reduced rather than immediately lost. So you'll see a progression of this loss of consciousness. and accompanying a sudden and growing severe headache and other neurological symptoms. And another good one, which I'm sure a lot of people might have had, is intoxication, and that is duration is much longer than a TLOC, and there's also an impaired consciousness. Again, using your clinical judgment, taking a history take, and also if they've got any alcohol photo, any alcohol breath as well, just to help identify if they are intoxicated. We also have the paediatric syncope. Okay, so diagnostic evaluation in paediatric patients is similar to that in adults. There are three specific conditions which occur in early childhood. That infantile reflex syncopal attacks, also called that pallid breath holding spells, or that reflex anoxic seizures, elicited by that brief unpleasant stimulus caused by vaguely mediated cardiac inhibition. This is when babies are taking pausing their breath. It is quite scary, but again, it's something to be wary of. You also got your cyanotic breath holding spells, characterized by stopping breathing during crying, leading to cyanosis and usually TLOC. Okay, so that's again cyanotic breath holding spells. They're holding the breath during crying. They're going blue, but the body will react. They'll start breathing again. So again, it's something to be wary of and to reassure your parents and carers. And you've also got your febrile convulsions, okay, where temperature is rising in that child and they'll have a visage and reaction to the rise by the heat. This is normally resolved, but again, treat what you find and follow your local guidelines, policies, and also administration of medication guidelines and policies and PGDs, etc. So that initial assessment, what we're going to do when we first come across this patient. So, Nice discussed the importance of the initial assessment. It's the same with any other medical condition or condition we go to and assess. It is important to ask the patient, as well as witnesses, if available, what has happened. So that initial assessment will help underpin a cause for the TLOC. So we want to know the circumstances of the event. What's happened from start to end? Did they stand up and have the episode? Were they on the toilet? Were they pooping? What was the person's posture immediately before loss of consciousness? Okay, so were they have an episode while standing? Were they sitting? Were they lying? What I know about the prodromal symptoms, such as that sweating or fainting or feeling warm and hot, could point towards a cardiovascular cause. What I know about the appearance, whether the eyes open or shut, and the colour of the person during the event. Did they go pale? Were they well perfused? Did they go blue? Want to see the presence or absence of any movement during the event. For example, that limb jerking and how long that happened. So the presence or absence of movement during the event, for example, that limb jerking and its duration, can point towards a neurological cause. Any tongue biting, again, you can identify if it's a seizure or not. Want to know if they've got any injury occurring in this event. So we're going to record the site and severity. They've got a head injury. Have they got a neck or femur fracture? We want to know the duration of the event, which is quite important as well. So the onset of the event to when they regain consciousness, that fully resolved episode. How long did it last for? Are they fully recovered now? Ask the witnesses or people there, if they know the patient, how are they? Are they acting normal? Is their behaviour normal? The presence or absence of confusion during that recovery period. So what is their GCS? Amnesia can happen post TLOC, so don't be alarmed. I want to know if they've got any weaknesses down at one side during the recovery period. Are they fast positive? If so, rapid excavation. If you can speak to the stroke team to get some advice, then please do, because it's always important to ask if you don't know or unsure. What else do we need to ask? Okay. We need to know any details of any previous transient loss of consciousness, including that number and frequency. We really want to know about the person's medical history and their family history. So their family history of specifically cardiac disease, any personal history of heart disease in the family, and also really, really important, a family history of sudden cardiac death at the age of 40 or less. So treat this as a red flag. In any of the following abnormalities are reported in the ECG printout. Okay, we also always need to do an ECG on these patients, because a family history of sudden cardiac death could mean a congenital heart problem, such as short or long QT syndrome, Brugada, Wolff-Parkinson, White. Okay, very important we ask this question. Want to know the current medications they're on? Okay. So, for example, are they on diuretics? Are they on ACE inhibitors, aldosterone receptor blockers, calcium channel blockers for their hypertension? Maybe they're dropping their blood pressure too much, etc. Are they eating and drinking normally? Have they eaten today? Could be contributing to low blood sugars or dehydration. So what to add and look for in our paediatric patients? Some aspects of the history can suggest a cardiac origin and should prompt cardiac evaluation. So again, we need to ask about family history, so any premature sudden death, cardiac death at the age of less than 40 years, and all family history of heart disease. You've seen trending, yes, as adults. Known or suspected heart disease. Any event triggers as well. Loud noises, fright, or extreme emotional stress. It can happen in our paediatrics, in our little tiny humans. A syncope during exercise, including swimming, cross country is a big one, especially in secondary school. And a syncope without prodromes, so whether supine or sleeping, or is it preceded by chest pain or palpitations? Ask them, you could ask the little our paediatric child, okay, did you have any did your chest feel like a beating drum? That could identify palpitations. Or if they're pointing to their chest, they're holding their chest, again, identify if they've got chest pain. Okay, it can happen. Again, we're doing the same examination, the same assessment, we're doing ECGs, etc. on these patients. So, what do we need to do now? We need to do our vital signs, our physiological observations. So our heart and respiratory rate, the blood pressure, lying and standing blood pressure, again, is clinically appropriate. Base this on your history. However, it is not bad nor harmful to conduct this, okay? And when you get them stand up, wait at least 2 minutes before conducting a standing blood pressure. But one on orthostatic hypertension, you don't actually necessarily need to do a standing blood pressure if you suspect that postural hypertension. If that patient gets dizzy, feels terrible and standing, tunnel vision, and these resolve when sitting, it is most likely to be that diagnosis. Don't put the patient through all them symptoms when you can actually take a good history and assess it. We're then doing a blood glucose and temperature. For our hospital conditions, we're going to be doing a full blood count, arterial venous blood gases, troponin, D-dimer. Again, all is clinically indicated during the assessment. A 12 lead ECG, this is a must, as you can see, and we're going to be doing our physical assessments, okay? So, the physical assessment. Remember, jar calc discuss. So, firstly, before we go on to jar calc, complete that most appropriate assessment, okay? If it is suspected cardiac, then complete a cardiology assessment, looking at all aspects, including auscultation of the heart. Okay, so for those paramedics or pre-hospital clinicians, Parapass by JARCAL has a great standby CPD on auscultation of the heart. And remember, JARCAL does discuss that auscultation of the heart is as part of the clinical assessment. So you got your S1 sound, that close of the mitral and tricuspid valves, loud and soft. The atrioventricular valves, you got the lub. The closure of the aortic and pulmonary valves, A2, the soft, the P2, loud and wide splitting of A2, and that semi-lunar valves, okay, the dub. We've also got the abnormal and so the pathological and physiological sounds, such as your S3 sound you might have. You can have this in heart failure, for example. So this sound is either pathological or physiological. It sounds like a gallop after the S2 sound. So normal, it can be normal in children and young adults. Okay, an S3 sound, like I said, is left ventricular failure is normally the cause of this. And if you have an S4 sound, which there's that gallop rhythm with an extra heart sound before the S1, so before the lub, and that is always pathological. There's always a reason for it. So it could be due to aortic stenosis, mitral regurgitation, and could mean an acute myocardial infarction sometimes. You've got your pericardial rub, so your pericarditis, and you've also got your murmurs, which and we need to identify when it sounds. Is it between your systolic or diastolic, so S1 and S2, or your diastolic S2 and S1? And then systolic murmurs can mean aortic stenosis. So Again, if you don't understand this, talk about what you find when you listen, okay? Discuss the sound of it. Is it loud or soft? You don't need to be specialists in heart sounds. Just document what you've heard so a doctor can actually go read your paperwork and go, right, the doctor or an advanced clinical practitioner or a practitioner can go, right, they've heard an abnormal sound on their examination. Let me have a little listen. We're going to be doing our neurological assessment. So look at everything from your cranial nerves through to the movement of limbs, speech, and more. Again, a really good app is MedSchool. This is an app which goes through the history examinations and investigations of actually literally every system and auto conditions. Brilliant app. Going to use your clinical knowledge and skills to decide what assessment is correct, and use your knowledge of anatomy, physiology, and pathophysiology. 12 lead ECG. Okay, so like I've mentioned a few times, we always do a 12 lead, and we are looking for these red flags. So these patients, again, according to NICE guidelines and a lot of research, that these patients need admitted to the emergency department, or if their symptoms are well, try the medical assessment unit or same-day emergency care. So if they have inappropriate persistent bradycardia, any ventricular arrhythmia, including your ventricular ectopic beats, that long QT and short QT. So remember, these do vary in adults for male and female, but corrected QT greater than 450 ms and corrected QT of short QT less than 350. We're looking for your Brugada syndrome, your ventricular pre-excitation, so that part of your Wolff-Parkinson White syndrome, left or right ventricular hypertrophy, abnormal T-wave inversion, your pathological Q waves, the atrial rhythmia sustained, your paced rhythm, and any new conduction abnormalities, such as your left bundle and your right bundle branch blocks, and any type of heart block, so your type 1, type 2, etc. So let's have a little look at Brugada syndrome. So Brugada syndrome is that rare, potentially life-threatening heart rhythm disorder that is sometimes inherited. There are 3 types of Brugada syndrome, which you'll see on the side, so you one. Okay, so we've got increased risk of ventricular and atrial arrhythmias, so the risk of ventricular fibrillation, ventricular tachycardia. The diagnosis cannot be made on the ECG alone, though. There needs to be other appearances of ventricular arrhythmias, such as your unexplained TLOC or family history of that sudden death. Hence why asking about sudden death in the age of 40 is very important. So your key features, you've got pseudo right bundle branch block, which can be a period in V1 to 3. You've got your ST elevation leads V1 to 3, and any ECG changes may be present at all time, or that actually can be transient and provoked. Hence why it's important to get an ECG as soon as you can. So we see here, your regards, you've got your type 1, you've got your code type ST segment, you've got your type 2, your saddleback type, and your type 3. Okay, and this is an ECG here of a Brugada. Life in the fast lane is really good for ECG as well, if you want to have a quick look online. Another one is Wolff-Parkinson White syndrome, WPW. So again, in Wolff-Parkinson White, there is an accessory pathway connecting the atrium to the ventricle. This can cause a risk of supraventricular tachycardia, your SVT, and if atrial fibrillation is present in these patients, there is an increased risk of this moving into ventricular fibrillation. So the key features of a Wolff-Parkinson White is that short PR interval, okay, less than 120, the delta waves, so that slurred onset of a QRS complex, which we have here in ECG, and you're also going to get a broad QRS complex. In those with that atrial fibrillation, there is no P wave basically. That QRS complex is regularly irregular, really confusing to say, and the QRS complex is broad but varying. A delta wave is present, on many complexes, but might not have some of them. Okay. So we see here, you've got your delta wave in your limb leads and chest leads here. Okay. So, when to advise and convey to the emergency department. So NICE guidelines, they quote, if the person presents to the ambulance service, take them to the emergency department unless a diagnosis of an uncomplicated faint or situational syncope is clear, which we're going to come on to. Okay, so this is where a perfect history take is important. Family history as well as social history. So all patients, where possible, should be referred to another clinician. If a patient presents with the following below, they ideally need to attend an ED. If they decline, ensure they understand the risk and safety net with the GP, again with consent, or if possible, see if they can get admitted into a medical assessment unit or same-day emergency care. So an ECG abnormality, as stated on the previous slide. So if we see an abnormality, this needs investigating, further including a full blood count. Heart failure, so history of physical signs, so it could be worsening of the heart failure. Medication may need an urgent review. Exertion, so the cause of doing something, was it caused by an arrhythmia? Is there an electrolyte disturbance, etc.? Especially in young people, we shouldn't be having a TLOC during exertion. Your family history and cardiac history, this puts the person at risk of sudden cardiac death. Constant monitoring as well as specialist referral is needed. New or unexplained breathlessness, so we need to find the cause. Conduct a well score for P, for example. A heart murmur, further stress on the heart, a type of murmur, systolic, any type of murmur, either systolic, diastolic, and any other heart sounds. And actually, over the age of 65, without any prodromal symptoms, so if they've got no prodromal symptoms, so no dizziness, heart sweaty, they need to be investigated. This could be a lot of reasons to offer transient loss of consciousness in those over 65, such as medications or arrhythmias like atrial fibrillation. And then, of course, we've got our first seizure and your new neurological cause, okay? Again, using just good clinical judgment and your clinical examination and your findings to decide. So when is it safe to discharge and refer to a general practitioner? So we have your uncomplicated transient loss of consciousness. So no further immediate management is required when diagnosing uncomplicated faint when there are no features that suggest an alternative diagnosis, and there are features suggestive of an uncomplicated faint, the 3 Ps. So we have posture, so that prolonged standing or similar episodes that have been prevented by lying down. Provoking, such as pain or medical procedure, so people say when blood's being taken or if there's been a lot of pain. And your prodromal symptoms, so feeling hot and warm. Is it a warm day? Also, please investigate as well for heat stroke, exhaustion, dehydration if it's a warm or hot day as well. One thing to mention as well, that brief seizure activity can occur during uncomplicated faints and is not necessarily a diagnosis of epilepsy. So just be wary that some people might collapse, might have what appears to be a seizure, but it only lasts for a very short, very short amount of time. We also have then your situational syncope. So diagnose situational syncope on the basis of the initial assessment when there are no features from the initial assessment that suggest an alternative diagnosis. So nothing at all which can suggest something else. If you found that it could be this or it could be that, it's not situational or uncomplicated. And the syncope is clearly and consistently provoked by straining during micturition, usually while standing, such as urinating, going to the toilet, or by coughing or swallowing, that vasovagal, and as like I said, straining on the toilet. So the uncomplicated TLOC can be referred to the GP. It is best practice for ourselves to speak to a GP or senior clinician. However, if this is not available, then the patient will have to do this. Ensure the PRF is left with the patient or a discharge form. If electronic EPRF, then consent has been agreed for the documentation to be sent to the GP. Ensure to document that you have informed patient to contact GP and that you have contacted the GP, and provide all worsening advice, so all the red flags, and write them down on paper and in your paperwork, so it's clearly written that you've given all the worsening advice and the red flags. So pre-hospital care, what can we do? Firstly, please don't be scared to pre-alert. Patients can be stood down from research to a normal manager's bay or assessment, so if you're unsure, ask for help, ask for advice, and don't be scared to pre-alert if you think this patient needs an urgent resource team. And remember, when pre-alerting, think, does this patient need immediate treatment right now? Okay, so a lot of the time, and if it is a transient loss of consciousness, it should have resolved. However, be prepared for any deterioration and for rapid extrication. Assess your ABCDs at all times. So conduct the physiological assessment and correct what we can. Raising legs or fluids for hypertension. Okay. Atropine for absolute bradycardia. And prepare for that worst case scenario. Patients who present with arrhythmias can suddenly deteriorate and enter cardiac arrest, like I discussed. If they've got Wolff-Parkinson and atrial fibrillation, then they can go into ventricular fibrillation at any time. So when your IVE access to prepare, the fibrillation pads at the ready, preferably attached to prevent the delay in shocks, provide pre-alerts readily, and prepared before life support. So, summary. Complete a thorough history. Complete your cardiac and neurological assessments. Conduct your physiological observations, including 12-lead ECG. Be aware of the red flags and what investigations are ED. So this is also covered within JCalc and it is written within JCalc. Understanding when it is safe to leave at home. So is it an uncomplicated or situational TLOC? Prepare for any scenario. Treat what you find. And ask for guidance and support if you're unsure. Use your clinical support desk, critical care team if needed. And even to the extent of phoning specialty doctors at hospitals. Phone your local hospital and ask for the on-call SHO, Reg, consultant for the specialty you need. Go away and research further, and as always, reflect on this. Thank you for listening, and please find my references for this presentation. Thank you ever so much.